Hello, I'm Dr. John Ayers. I'm a medical oncologist and hematologist at Northwestern Medical Group, and I work at the Western Cancer Center, which is in Warrenville, through Central DuPage Hospital. And I'm here through LivingWell for Facebook Live to talk about estrogen receptor positive breast cancer, how it's treated, and how we can make the treatment hopefully better in terms of the normal treatments to just go after the estrogen receptor, and then other ways to treat it, which is through targeted therapies, which make the endocrine therapy work even better. So the one thing to talk about is what is estrogen receptor positive breast cancer, why is estrogen such an important part of the treatment or controlling estrogen, and it is because of normal breast cells have estrogen receptors, and just not a lot of them, and they're stimulated to grow just a little bit, maintain the breast tissue through estrogen receptor stimulation. Breast cancer cells, however, have many estrogen receptors on them, and when they get stimulated, it's going to stimulate the cancer cell to perform what cancer cells do, which is to grow, divide, be immortal, and spread to other places. And that's what we don't want it to do. So the most important things, one of the most important things to do for patients with estrogen receptor positive breast cancer is to take estrogen away from these cells. And we can do that in multiple ways, but primarily it's two ways. One way is to block the receptor or modify the receptor, and that's with drugs like tamoxifen, which is a pill that can be taken that fits perfectly into the estrogen receptor and shouldn't stimulate it. And so now the estrogen receptor is filled with the tamoxifen and can't be stimulated by estrogen. Another way is with a drug called fulvestrant, and that's an estrogen receptor downregulator. It degrades estrogen receptors and makes the signal from the estrogen receptors not work. And so that is also effective. It's used later on in the course of things, and that just has to do with how it's been studied. The third way is to degrade estrogen completely, or completely get rid of estrogen in the body. That only works if you're postmenopausal. So that could be because you have gone through menopause and the ovaries are no longer functioning. Could be because your ovaries have been removed. It also could be because we're giving an injection. So there are ovarian suppression drugs that we can give, like goserelin, and that will suppress the ovaries while you're getting it. And these all work in conjunction. So if you eliminate if you either don't have estrogen production from the ovaries, or you suppress that production, that's most of the estrogen in the body, but the last place that it's being made is an enzyme called aromatase. And aromatase is mostly found in the fat, but it's also found in the skin, the bone. It's also found in breast cancer cells. Breast cancer cells contain aromatase, so they can make estrogen for themselves to stimulate themselves. And so a very effective way to get rid of estrogen is going to be to turn off the aromatase, and that creates a scenario that we'll sometimes refer to as supermenopause. Where menopause is, there's no ovarian function. Supermenopause is that there is no aromatase function either, and so there's basically zero estrogen left to stimulate the cells, and that's very effective at killing the cancer cells. So endocrine therapy is given in multiple settings. The most common setting we'll give it is in the adjuvant setting, and so 80% of breast cancers have estrogen receptor expression. And we'll give one of these drugs to patients who have had their cancer resected And we just know that statistically there's a chance that a cell escaped before the cancer was resected. And if it's there, it's going to not be detected by any test we have. It just needs time. It needs time and estrogen to get stimulated to grow and turn into a tumor, perhaps somewhere else in the body. It could be the bone, the lung, the liver. And so if it's hiding there, it's a clone of the cells that were actually removed from the breast cancer, from the breast itself. And if those cells in the breast were estrogen receptor positive, the expectation is that any cell that escaped would also be estrogen receptor positive. And so they depend on estrogen to grow, so we're going to take estrogen away from them. If you're premenopausal and you're over 35 years old and have lower risk disease, we'll usually use tamoxifen, because they found in a large trial called the SOFT, S-O-F-T, and also the TEXT, T-E-X-T trials, that tamoxifen works really well for those patients, and they generally don't need to take that extra step to do ovarian suppression. For a patient who's under 35 and or has higher risk disease, meaning someone who maybe had lymph nodes positive or has a disease that required chemotherapy because of a high genomic score, like those tests that we do, like oncotype testing. Those patients will benefit from suppressing the ovaries if they're premenopausal and then taking an aromatase inhibitor. We'll usually give that for 5 years, and that you have to then talk about what to do after the 5 years, because the natural history of breast cancer is just such a long process. It can come back at the most common time is the first 5 years, but it could come back any time over the next 20 years. And so we do have studies and we have discussions when we get near that 5-year point to talk about, should we be giving 10 years of therapy to protect patients for longer and prevent those late recurrences that we don't want to see. In patients who already have metastatic disease, whether it presented with metastatic disease, or sometimes for a patient whose cancer did come back and returned as metastatic disease, we will give their first treatments are also going to be endocrine therapy in most cases if it's an estrogen receptor positive cancer. And it's not only because it's much better tolerated than things like chemotherapy, it's because it's actually more effective as well. And so we generally, though, don't give just the endocrine therapy. In those cases, we're also going to give other medicines that will make the endocrine therapy work even better. And if it's the first line therapy for someone with metastatic estrogen receptor positive cancer, so metastatic means it's somewhere else in the body, big enough for us to see, we don't know how to cure that, and so we don't try to. We manage it, and hopefully we're going to be able to manage it for many, many years through therapies that will be relatively well tolerated. So we will generally give a pill like letrozole, anastrozole, or exemestane. Those are the 3 aromatase inhibitors. And in that case, we'll generally also find one way or another to make sure that the patient's going to be menopausal, because we want to optimally treat their cancer. And that's going to be a part of the treatment in the long term, is going to be to take away the ovarian function. But we won't give that alone. The first line therapy, we'll usually give it with a class of drugs called CDK4/6 inhibitors. So CDK stands for cyclin-dependent kinase. And if you remember from biology class, the cell cycle, how cells will divide, they go through a cycle, and it needs these enzymes to get them through the cell cycle. So if we give a CDK4/6 inhibitor, it's going to block an enzyme. So it's targeted therapy, and it will stop cells that are growing more quickly. So we'll also see maybe some decrease in the white blood cell count. So the drugs that we give are generally given two of the drugs, palbociclib and ribociclib, are given for 3 weeks on, and then you take a week off to let the white blood cell count recover. And then there's a third one called abemaciclib, which is taken twice a day and taken every day. They all three have different side effects, different side effect profiles. The palbociclib and ribociclib tend to drop the blood counts more. The abemaciclib can cause some more diarrhea and maybe a little more fatigue. But they're basically going to double the chance that we're going to get a response out of the treatment, out of the hormone therapy or the endocrine therapy, and it's also going to double what we call the progression-free survival, meaning it's going to double how long that is going to work before we have to switch to another treatment. And so we always want to try to get as much as we can out of these treatments, because we would like to put off giving drugs like chemotherapy as well. For patients with metastatic disease, we'll eventually work towards get through all the endocrine therapies, and we'll be left with chemotherapy. But we want to get as much as we can out of these endocrine therapies, and this is one way to do it, is by adding a targeted therapy to each treatment. So a common way that we'll treat is we'll give an aromatase inhibitor with a CDK4/6 inhibitor, and do that for hopefully a number of years. That's a good case scenario. It will stop working eventually. And then we've got other options that we can give. One is to switch to the drug fulvestrant, and the fulvestrant is a drug, like I said, that works by downregulating or getting rid of those estrogen receptors. And so it can work on its own. It also can work in some patients. More than 40% of patients will also have another mutation. We have to test for it. We have to specifically check the tumor for it. It's called a PIK3CA mutation. And if you have this mutation, that means that the product of that mutation is what's driving the cancer, or part of what's driving the cancer. And so for those patients, we can give a drug called Piqray or alpelisib. And that's a drug that's just a PIK3CA inhibitor, and it will block that enzyme, and it's going to also double the chance of the drug working, and double the time before we have to stop the drug, the progression-free survival. It has side effects too. It can cause some fatigue. There's a rash that can come with it. Diarrhea can come with it. And a strange thing is that you can have elevation in your blood sugars. So for some patients, it's not a big deal if they're starting off without that issue. But for patients who already have diabetes or pre-diabetes, that's something that we really need to watch closely while they're taking it. The next treatment, if we are going along this course, is to typically give a drug like exemestane as an aromatase inhibitor. So exemestane is a little bit different than the other two aromatase inhibitors. It's got a steroidal component, and by itself it can work if a patient's been on letrozole or an anastrozole, then you can give them exemestane, and sometimes even by itself it can be effective. But we'll typically give it with another drug as well. And this drug is called everolimus, or Afinitor is the other name. And it is an MTOR inhibitor, which is another enzyme. It's an enzyme, the long way to say it is mammalian. Well, you don't need to know that. So it's an enzyme that within the cell will actually stimulate the estrogen receptors as if there's estrogen there, and the cell will behave as if there's estrogen around, even though you're on you're on this pill, the exemestane, that gets rid of estrogen. And so if you also block that enzyme, the mTOR enzyme, you'll get another benefit where you'll get better response rates and longer progression-free survival. So the side effects from that are you can get, one of them we used to get a lot of. When we first started, we were learning how to give it. A lot of patients had mouth sores, and they were very painful. Nowadays, it's much less common because we give a steroid with it, oral steroid rinse for the mouth, and that dramatically decreases the mouth sores that patients get. They can also have fatigue with it, and we have to watch for interstitial lung disease, which we would do with exams and even chest x-rays and then our serial CAT scans as we're monitoring patients. And that's something that we will, if it does come, we can stop the drug, give some steroids, and then commonly we can get the drug, we can restart the drug again, perhaps at a lower dose, and still get some benefit from it. These drugs can also be combined with other treatments that we have. So if a patient also happens to have HER2 expression, we can combine the endocrine therapies with the anti-HER2 drugs. There's not studies so far that have approved using the targeted therapies with that, but in those patients, if they have HER2 amplified or HER2 positive cells, we're not going to want to miss out on giving anti-HER2 therapy. That'll be a more important aspect of the treatment. At this point, we can maybe take some questions, or are there any questions?
That'd be great, Dr. Ayers. A question came in asking the endocrine therapies that you've talked about, is this for metastatic disease?
It can be. So if it's estrogen receptor positive metastatic disease, then we use the same drugs. The difference is that we will use the targeted therapies with the endocrine therapy if it's metastatic. One exception would be abemaciclib, and that's something that has evolved right now. We are using it. I've been using it in patients who have very high risk disease that's been resected, that's estrogen receptor positive. There was a study called the Monarch-E trial where patients were given abemaciclib after chemotherapy, and there was a little bit more benefit. But all the endocrine therapies, for the most part, for where we are right now, and this will be different, 2 years, 3 years, 5 years from now, it would be a different lecture that we would give, because we'll have new data. But as of right now, these drugs are primarily given in the metastatic setting, and then we give the endocrine therapy alone in the adjuvant setting, in the setting where we don't even know if there's cancer there or not, but we just know statistically you're going to do better if you get on some endocrine therapy, and you'll have less of a chance of it coming back. And everything we ever recommend is always, we never know for the person we're recommending it for. We just know because a trial's been done, and thousands of brave women have signed up for these trials and enrolled, and one will get one treatment, the other will get maybe a brand new treatment that we're finding out if it works, and if it is better, then everybody gets to benefit from that once that drug gets approved.
So another viewer is asking, did you need the meds if you've had a complete hysterectomy? She mentions she had 10% estrogen in breast, 2% in lymph nodes, and is BRCA1 positive. Yeah, so and if this is recent, in the past week, we have new information for you. If you're BRCA1 positive, and it's a lot of caveats, if you had chemotherapy first, and then had resection, and then had some residual disease, there is a drug. They just came out with new guidelines this week using a drug called olaparib, which is a PARP inhibitor. PARP is an enzyme that proofreads genetic mistakes, just as BRCA1 does. So BRCA1 is a proofreading gene. If you have a mutation in there, you accumulate mutations much more quickly, which leads to breast cancer. But they just presented data
in early June that showed, it was the Olympia trial. And that showed that if the patients who take a PARP inhibitor for a year after it get added benefit, more reduction in the risk of recurrence. Having 10% estrogen receptor expression, I would still treat that adjuvantly, meaning I would still recommend endocrine therapy. And if you had a hysterectomy, or if you're ovary, and to us we say oophorectomy, that means that your ovaries are removed. Then you're not making estrogen from your ovaries, but you are still making estrogen through the aromatase. And you have it, like I said, everywhere in your body, including your fat and including the cancer cells themselves. So one way or another, if you're postmenopausal, I would generally recommend an aromatase inhibitor because it's about 20% more effective than tamoxifen at preventing cancer from recurring.
Speaking of tamoxifen, a viewer is writing in experiencing horrible hot flashes and cold spells due to tamoxifen. Is there any food that should be avoided if we're taking tamoxifen? And are these symptoms normal, the hot and cold?
Yeah, I won't say normal, but I will say common. And it's just, you have estrogen receptors in the blood vessels of your skin. And if they don't get estrogen, they tend to dilate. And so it's a bunch of blood rushing to your skin. And, many women get that just with menopause itself. There's less estrogen and they get hot flashes. Other women will get it if they take one of these drugs, and it could be the tamoxifen that can do it. It could also be an aromatase inhibitor. Both ways will take estrogen away from those blood vessels. Eventually, they figure it out, and that's why for most women, and that's why usually women who are in their 60s and 70s aren't still having hot flashes. Some do, but most don't. So eventually, the blood vessels will figure it out. In the meantime, there are treatments that can be done. Some work better than others, and it's all individual. So many times we'll try giving a drug like Effexor, which is a antidepressant. And that in a randomized trial was shown to reduce the risk or reduce hot flashes. That class of drugs is also associated with the potential that hasn't been proven in terms of actual patient outcomes, but there's the potential that they may reduce the efficacy of tamoxifen. And so some patients don't like the idea of taking something like that. I have also used progesterone for patients. There was a trial that was done. It was a small, non-randomized trial giving progesterone, and I'll usually use it for a relatively short period of time, get control over the hot flashes, and then try to wean off of the progesterone and see if that's effective. Depending on what you're taking tamoxifen for, there's another option. So let's say if it's for ductal carcinoma in situ, there was an Italian trial called the TAM-001 trial where they gave lower doses of tamoxifen. And it wasn't compared to full-dose tamoxifen, with full dose meaning 20 milligrams a day. But I will consider that. I'll usually say let's start with what the standard is, which is the 20 milligrams a day. And if we just can't do it, if a patient says, I just can't live like this, then we have to come up with another plan. And there's almost always something else that we can try. And that's why I'll always want patients to tell me about their symptoms, even if it's in between visits, because I don't want them to stop it on their own and then find out at the visit that they've stopped it. I'd want to see if we can try to figure out a plan B, a plan C, something else that we can do to try to keep you on it. Because we always want to know we did everything we can to prevent cancer from coming back. Even if it's a small benefit, we always want to have that feeling like, we tried everything to keep you on it.
So 2 follow-up questions to the tamoxifen. Have you ever come across a case where tamoxifen causes premenopausal women's ovaries to hyperstimulate? And why do you recommend an oophorectomy?
So I'll start with the timing that I'll recommend an oophorectomy is for a patient that I am convinced, based on the clinical trial, which was that SOFT and TEX trial, that was the one that looked at premenopausal women with estrogen receptor positive disease. It was 2 trials, actually, they combined, and asked, is it better to be on tamoxifen plus either suppression of the ovaries or oophorectomy, or an aromatase inhibitor plus suppression of the ovaries or oophorectomy. And if I'll usually do it in a stepwise way, if I have a patient who's at high risk, meaning they're under 35 years old or have higher risk disease, lymph nodes positive, or just higher risk that because of perhaps their genomic score, then I'll recommend that we try to get them on the best endocrine therapy, and that would be, usually I'll do it stepwise. Start with tamoxifen, see how they do. Then add ovarian suppression and see how they do. Then get them onto an aromatase inhibitor, see how they do. And then if everything is okay and they're like, okay, I could do this, most women, or a lot of women who are younger, would rather not do an injection once a month for many, many years, and then we'll discuss trying to get their ovaries out. The other scenario is for a patient who has estrogen receptor positive disease and it's metastatic. And so we know that the best treatments are going to be for patients who don't have their ovaries, are going to be postmenopausal, and so I'll recommend that because it's more of a long-term thing that we're going to want to get there. And then the other question was about the hyperstimulation. I have not seen that. I've only seen that with patients who are getting, we'll meet them and maybe we're going to do a treatment where they're going to need chemotherapy, and so we'll want to harvest their embryos before they start any chemotherapy and maybe make them not able to have children. And so I've definitely seen hyperstimulation syndrome with that, but I've not seen it with tamoxifen itself. It would be I think a very rare side effect.
Okay, next question. Why would one take a certain AI over another? For example, why would one be on anastrolol versus exemestane? Also, if one is finding their AI intolerable, would you suggest going on another AI?
We call that the aromatase inhibitor shuffle. And it actually can sometimes work so I'll usually pick the AI. They've been compared against each other. They're considered equivalent. If I have someone who has a BMI that's high, I might tend to pick letrozole compared to anastrozole. And it's not based on any clinical data. It's just how well it may inhibit the aromatase. But otherwise, anastrozole is great because it's usually the cheapest of them. It has the longest data. Some of us, not based on data, believe that exemestane may be the best tolerated, and so that one way or whichever way we start with, that's what we'll commonly do. If we have a patient that we're starting an aromatase inhibitor, they have really bad symptoms, you stop it, let them just kind of recover and kind of get their feet under them again, and then pick another one. If they're up to trying it again, and the issue that I've seen has been the joints, and the joints, the arthralgias or achy joints, and it's a stiffness that when it's when you've been sitting for a while or lying for a while, that first movement is just so stiff, and then you move again and you kind of feel a little bit better, and then sit down again and have to start all over. So patients tell me that the best thing to do is keep moving, to not take a lot of breaks and just try to keep moving as much as possible. Glucosamine chondroitin can sometimes help. I'd say maybe a third of the time I've seen it benefit them, but there's not a lot of great answers because it usually starts with some joint problems that you have, and that only get worse because estrogen just feels good in the joints, and we're getting rid of estrogen. That's our goal, is to get rid of the estrogen for the cancer, but it also helps with a lot of other things in your body, and it doesn't feel good to not have that estrogen.
Okay, last question, Dr. Ayers.
Mm-hmm.
Do you really have to take hormone treatment for 5 years to be effective?
So it would be effective. Like 3 years is better than nothing. 2 years is better than nothing. The first 2 years appears to be the most important, and especially for an aromatase inhibitor. To get those first 2 years of an aromatase inhibitor appears to, like, if you're going to say what's the very basic that you should get, and then they've done studies. There's a study called Big 198 where they then switched to tamoxifen for half the patients. And at 8 years at least, it's the same outcome. And so I definitely offer that for some of my patients who, if they get on an aromatase inhibitor and are really struggling, then I want to be able to offer them, something, like have them on something. And so to switch to tamoxifen, if you can make it 2 years and then switch to tamoxifen, which is usually better tolerated, then that's a good option. There's data to give 10 years of therapy, and it's because of, if you have estrogen receptor positive disease, it's such a long natural history. If you're going to say, when does the recurrences happen, and just less than half of them occur, if it were to happen, just less than half occur in the first 5 years. Most of the recurrences, your risk is actually higher of recurrence after year 5. And it can be year 7, it can be year 17. And so we get to see that stuff. If you've been practicing long enough, you get to see these patients whose cancers come back so late. And it's horrible to see, and we want, so we are always motivated to try to prevent those recurrences too. Now, I would say the benefit for more than 5 years is pretty small, but it's there in some patients, and we have some ways that we can figure it out. One way is to do a calculation. It's called a CTS5 calculation based on your age, your tumor size, the tumor grade, and lymph node status. Another way is to do a genomic test. So it's called a breast cancer index. Your tumor is going to be saved. It's going to be we keep it for 10 years. So we can request your tumor, get sent to a lab called Biotheranostics, and they will run testing, quantifying genes for proliferation and estrogen receptor expression. And they will tell us if you have a high risk of recurrence just based on the gene expression. If your risk of recurrence after year 5 is high, and then it'll also tell us if there's going to be a significant benefit from another 5 years of therapy. And so we always feel helpless as oncologists. We don't actually have control over whether the cancer is going to come back or not. So when someone wants to know, do I really need to do this? We actually don't have that answer. We don't know one person versus another person whether it's going to come back or not, whether treatment's even going to really if you need more treatment to help you. We've been there on the other end, though, when we've seen if it does come back. And most oncologists, myself included, first thing we'll look at is, did we do everything? Was there anything else we could have done to prevent this from happening? Because that's the absolute thing that we want to prevent. And so we'll always try everything that we can to get the optimal amount of treatment in, and I would say that is going to be 5 years if you can do it. In some patients, 10 years if needed, and if it can be done.
You got time for one more question,
Sure.
Dr. Ayers? Can you talk about the relationship of soy and ER-positive breast cancer?
Yeah, so soy has phytoestrogens in it. They're very weak estrogens, and there is thought that biochemically, if you take in phytoestrogens, you might stimulate breast cancer cells. the thing that, I'll just say that there's no actual real evidence for it. And in fact, if you look at populations, if you look at, let's say, the populations in Asia where they eat a lot more soy than we do, they actually have less breast cancer than we do. And it's probably because their body mass index is lower and they have less fat. We can make a lot more estrogen than you can take in with eating some plants. Our bodies do. Men and women have aromatase in us, and we can make a lot more than that. So I usually will tell patients moderation. Probably not have a big can of soy powder that you're eating on a regular basis, but if you have some tofu, I love tofu, that's fine to have. If you're going to have products that have some soy, it's okay.
All right, I think we're good. Thank you so much for your generosity with the time and the questions.
Thank you. No, it was a pleasure.